Welcome, everybody, dear friends of endoscopy. We are back with another episode of our EndoTalks. This is kind of a premiere because it's the first one which is sponsored by one of our sponsors. As we all know, there is a relationship between sponsors and us. And I can say we only have sponsors whom we appreciate, where we are more or less convinced of their products. And actually, there's no one better to have this interview on a specific topic, which is artificial intelligence, sponsored by PENTAX, than Peter Sirsima. So, Peter, a very warm welcome.
Thank you, Thomas.
And Peter, you are a long-term friend, not only, but you are editor of endoscopy, editor-in-chief. So, I mean, you know how to deal with that. And I'm very much looking forward to the topic artificial intelligence. Everybody speaks about it. So the PENTAX Discovery system, you have experience. Can you show us a few examples and what you are doing with the system?
Yes, I will show you some examples. This is indeed about the Discovery system. And of course, thank you very much for the introduction. As you said, we are longtime friends and most likely we will stay that for another long time. So I'm looking forward to that. Discovery system that was developed by PENTAX, and well, we were lucky enough to have some experience now with the system, and we have done a prospective study, and now also are performing a randomized controlled trial. This is my conflict of interest statement. And these are the 90 patients that were included in this first prospective study. 3 centers, one from Italy, one from Germany, and our own center in the Netherlands. And as you can see, the mean age of the patients that were included was 62 years. Majority of patients were males, and the indication for colonoscopy was diagnostic, screening, non-IFOBT, and also surveillance patients. And this is the first video that I like to show. This is a patient that came for surveillance. You can see that the colon is nicely cleaned. There are a couple of false positives, but definitely there on the right you see a true positive, and this polyp was removed. Of course, although it was a very small one and most likely not an adenoma, we thought, but we still removed this video. Yeah. And of course, we use this system upon withdrawal of the endoscope. That's the most convenient way of using it. You can also use a sound that highlights your eyes to the sound and to the image. Personally, I'm not using any sound. I like to watch the screen and watch the boxes that are appearing.
Peter, I fully agree with the sound, so especially with the false positives. But I would like to ask one question on the video, and that's false positive, because I have some troubles with the definitions. If there's a little bump somewhere, this is something even without artificial intelligence you should have a look at. So I'm not sure, you know, you have to check all bumps, haven't you? So it's not maybe a true false positive.
Well, that's true. I mean, it's about the definition and I agree. When you see some kind of polyp type lesion or bump or whatever you call it, then of course you should make yourself clear that it's not really a adenoma or another lesion that needs to be removed. And the 2 lesions that were seen in the beginning of this video were indeed suspicious for a polyp. So you're right, this is not a true false positive. The real false positives are, of course, the fecal materia and all the other abnormalities that are not normal for colonoscopy.
Or perhaps if a thickened fold is constantly shown as a polyp,
true,
you know, over a long time, that might be a false positive. Yeah. But the other issue you mentioned is fecal material. So and this colon was perfectly clean. So how does the system behave if the bowel is not so clean?
In general, quite well, of course. I mean, it should not be too dramatic, but if there's only some dirt and not too much, then it is not generating a lot of, as we call it, false positives. And I will show you also in one of the next videos an example of that. Maybe I move on to the next slide. So this is the next video, the second video that I would like to show. And that is actually, well, you saw there was some fecal material over there, but it was not lighting up in the AI mode. And there's some more dirt there, but again, it's not lighting up, and I think that's important. And what's also important, it's also lighting up the AI system when eye scan is used, and of course that's important because that's also, well, during the examination we also use eye scan or the other systems that are currently available to make a classification of the lesion a little bit easier. And here you see that the polyp is being removed with a cold snare polypectomy.
Okay, so we have seen small polyps, and there is one polyp, especially in the right side of the colon, which is very tricky because it can be super flat and gloomy. That's the sessile serrated lesion. Do you have any experience? What does the system say here?
Yeah, that's a very good question because you know that we are struggling. The systems are struggling with serrated lesions at the moment, but quite remarkable. In this pilot study of 90 patients, we did have a serrated lesion detection rate of 11%. So suggesting that Discovery is also detecting serrated lesions in the right-sided colon. And maybe I should move on to the next video. This is another video. Here you see again that there's a bump over there, but that was not counted as positive. But this one was counted as positive, and this was clearly a serrated lesion that was detected by the Discovery system. And of course that's important as you mentioned, because what we think now is that most of the missed lesions that we see or that we miss in the colon are serrated lesions, and that's the reason for a post colonoscopy miss rate that is definitely not zero at the moment.
Okay. The serrated lesions are something worrisome because where have these lesions been 15 years ago? So we only started to see them and recognize them rather recently during the last 10 years. So it's reassuring that they are targeted by this system as well. And I think that's something for the future. Is there any example of other lesions, you know, like diverticula, or what you find? Is the system also highlighting them, or only polyps?
Yeah, no, it's sometimes also picking up these diverticula, especially when they look maybe in the future a little bit like polyps or adenomas. But in most cases, a diverticulum is negative with the system. And of course, that's important. And especially in those patients that do have a lot of diverticula, then you should not have too many of these, let's say, false positive notifications. So that's indeed an important message to give here. Maybe okay. I should.
Do you have another video example for us?
Yeah, here's a little bit larger lesion, as you can see. Not difficult to miss. At the same time, it's a little bit hidden behind the fold, well, it could have been missed if the system had not alerted our eye to this lesion, and that is being done over here. And I think it's a nice example of a adenoma that was detected by the Discovery system. And then it is brought to the 6 o'clock position, and then of course it's very easy to remove the lesion. Okay.
Do you have any data of the pilot study, and maybe you can tell us about the randomized trial a little bit?
Yeah, well, I will show you some results of the pilot study in a moment. We are now running a 9-center randomized controlled trial, almost completed, including almost 500 patients, and randomizing between standard colonoscopy versus colonoscopy with Discovery. And of course, we are anxiously looking at the results. We have no results yet, but that is definitely something that will be known in the next few months.
So I guess with 500 cases, you're going for a significant difference of 7 or 10% or something.
Yeah, the power calculation was based on 10% difference. Yeah.
Okay. Good. So could you show us what you have seen in the pilot study?
I can, but maybe I can show you one other video, and I think that's also an interesting video because it's actually an angiodysplasia that you see here in a moment, and also fecal material. And what you can see is that the system is not lighting up. So it definitely shows that it's only lighting up, or mainly lighting up when it is seeing polyps or adenomas, but not angiodysplasias. And I think that's also an important message to bring here for this webinar. Let me go then to some examples, to some results. Here you see the results of 87 patients, the number of polyps removed. The majority of patients had at least one polyp, as you can see. Size, and that's of course important to mention here. Most polyps were smaller than 5 millimeter. And of course, that's an important something important to discuss, because at the same time, what is the importance of these diminutive lesions? And that's something that needs to be figured out. At the same time, if we recognize them, and we would also be sure that this lesion is not a adenoma, we could also decide just to leave it and not to send it to pathology, or maybe when it is in the rectum to leave it in place and not worry about it too much. The Paris classification and also the histology conclusion, majority adenomas, and again, what I mentioned before, also the serrated lesions in 13% of patients that were detected by the system. The polyp detection rate 55%, adenoma detection rate 28%, serrated detection rate of 11%. Polyps per colonoscopy 1, median, adenomas per colonoscopy 0, but the mean was almost a half, and a serrated polyp detection rate 0, but again 0.13 mean. And then some other important information, the number of additional polyps discovered with CADe. The median was 0, but there were some polyps in which the endoscopist had the feeling that it was discovered by the system and not by himself or herself. The number of polyps missed with CADe, 0 at the same time. I think that's not easy to determine, of course. At the same time, that was mentioned by some during some procedures, which I think what is also important is the frequency of false positives. And as you can see, 0 to 10 false positives, 10 to 20 or 20 to 50. And as you can see, the majority of false positives were 0 to 10 or 10 to 20, as you can see here in the frequencies. And the user-friendliness of the system was rated as 8 on a scale from 0 to 10. Finally, an interesting slide, maybe, because it shows all the studies that are currently available with CADe systems. Not only, this is only Discovery, these are all other systems. As you can see, the majority of studies are from China. So far, most of them were RCTs. Most endoscopists were experienced endoscopists. A large number of patients included. The indications. What I think is interesting is that the polyp detection rate with Discovery was 55.6, which is in the higher range as compared to other series. And the adenoma detection rate more or less the same as other series. And the serrated detection rate, as you can see here, the highest of all studies published so far. And here again, some information about the polyp size, which, as I mentioned before, and it's also seen in other studies, was very high. Most polyps were small sized, below 5 millimeters.
Okay, so thank you very much, Peter. I think these feasibility studies are very important, and you should probably do them before you start a randomized trial. because you can generate your hypothesis, what happens, and so on, and avoid underpowering of studies. So the remarkable fact may be the sessile serrated lesions, so we will see in the actual study. There's also something like a training effect. So I think if you work with a system, it might train your eye and you might become better. But we are very, very curious what will be the outcome. Peter, at the end, I have two practical questions. One is back to the topic of false positives. People say, okay, all these small polyps, would we be forced to remove too many hyperplastic polyps?
Well, I think that's a very serious and very good question to ask, and that's of course one of the concerns that we are discussing now. When we see too much, what are we doing with all this information, and is it really has it an effect on the patient's prognosis and survival? And I agree that is something that needs to be discussed. At the same time, if we could combine these systems also with a system that is also telling us that this is a hyperplastic lesion or an adenoma, then of course that could also help us in deciding whether we bring this lesion to the pathologist or not, or maybe even in the rectum decide not to take them out and just leave them in place. So I think that's at least what we need for the future. Not only not only detecting a lesion, but also characterizing the lesion and making sure that the lesion is really important or not.
Well, that's almost my second question. The consequences of differential diagnosis. I think it has a lot of legal implications. So I mean, it might be different from country to country, but in the Netherlands, what would be necessary that you are allowed to throw a polyp away?
That's of course a discussion that's only starting now. But of course, if this, you can imagine that, for example, if you decide to throw a polyp away and at the same time, at the same place, there's in a couple of years' time, a big cancer. So that means that maybe in the polyp there was a cancer, that could have legal consequences. And I think that needs to be discussed, and also needs to be made sure that there's a solution for this, and that this is accepted as a risk of the system. At the same time, that maybe the advantages of the system are much more important than the disadvantages that are also likely to exist as well when using AI systems for polyp detection.
And in general, I think it's our nightmare, the interval cancers, a patient coming back with a cancer after a normal colonoscopy done by us a year ago. So this might not be specific to that issue. It's a general issue, but I think, as you pointed out, it's unsolved. So may I finish with a philosophical question about the small adenomas? What's your feeling? We are hunting more and more small adenomas. At the same time, we have data saying that people with small adenomas have the same prognosis as the average population. So are we on the wrong track? Should we more go for the sessile serrated, for the larger ones? What's going on?
Yeah, I think we're on the wrong track now. I think there's too much emphasis on these small lesions, and I think that also reflects now the discussion, of course, that we have on the surveillance intervals. Are they not too short at the moment? If you have done a perfect or at least a good quality colonoscopy, I think the emphasis should be on the larger lesions. These patients are important to follow up. At the same time, maybe also those patients that have at least a couple of serrated lesions in the right-sided colon, I think they are also worthwhile to take very, very serious. And I think that's the group of patients that we should really worry about.
Okay, I understand. So we are only at the beginning where artificial intelligence could help us. First step is detection because it's the easiest one. Next one is differentiation, but because also the systems could interfere with management, patient recall system, etc., etc. So that at the end, AI helps us in the full spectrum of colonoscopy and polypectomy.
I agree. And I think also what we see now, also these AI systems that are measuring some quality parameters of colonoscopy, and that also will help, of course, to differentiate between poor performers and good performers in terms of doing colonoscopy. And I think that's also important information to have for the future.
Okay, Peter, this was a very interesting and very nice talk. I thank you very much. As we are both in the editorial business, I don't think we have to be worried because there will be enough papers in the future about AI and all its ramifications. I thank you, dear friends of endoscopy, for watching us, and welcome back next week. Peter, goodbye, and thank you very much.
Thank you very much, Thomas.